Bronchoscopy involves inspection of the interior of the tracheobronchial tree through an instrument called a bronchoscope, endoscope. The two types of bronchoscopy include flexible fiberoptic bronchoscopy and rigid bronchoscopy. Surgical bronchoscopy always includes diagnostic bronchoscopy when performed by the same physician. The scope can be inserted through the nose, mouth, endotracheal tube, or tracheostomy site. Tracheobronchoscopy through established tracheostomy incision. The physician views the airway using a bronchoscope placed through an existing tracheostomy. The physician examines the conducting airways. The bronchoscope is removed. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, diagnostic, with cell washing, when performed. The airway is anesthetized. The physician inserts the bronchoscope through the upper airways, noting any abnormalities. The vocal cords are visualized and the structure and function are noted. The bronchoscope is advanced into the tracheobronchial tree. All of the airways are inspected. It may also include the obtaining of diagnostic specimens as part of the examination. This may be done with or without fluoroscopic guidance. After diagnostic visualization of the bronchus, cell washings may be obtained through the bronchoscope. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with brushing or protected brushings. Sample lung tissue is obtained with brushings or protected brushing through the scope. The brushing is performed over visualized abnormal mucosa, possible tumor, or the brushing may be performed peripherally into the area with an infiltrate. Brushings or protected brushings take significantly more time to perform than bronchoscopy with cell washing. Protected brushings involve passing a catheter through the bronchoscope into an area of the diseased lung, often with the use of fluoroscopic guidance, not reported separately. The catheter seal is broken and an uncontaminated brush is then advanced beyond the catheter to obtain specimens for culture and sensitivity, or an unprotected brush is used to take samples for cytology and microscopic examinations. Several passes of the unprotected brush may be required and are included in the overall procedure. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with bronchial alveolar lavage. The bronchoscopy includes bronchial alveolar lavage, which allows lung tissue to be sampled by irrigating with saline followed by suctioning the fluid. The bronchoscope is removed. Bronchoscopy with alveolar lavage, which is not the same as routine washings. Bronchial alveolar lavage, BAL, allows the recovery of cells as well as noncellular components from the epithelial surface of the lower respiratory tract. This differs significantly from washings, which refer only to the aspiration of secretions or small amounts of instilled saline from larger airways. Bronchial alveolar lavage involves repeated installations of sterile saline occurring in aliquots with aspiration into one or more containers. Large amounts of saline are pushed into the airway and then recovered by suction. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with bronchial or endobronchial biopsy, single or multiple sites. The physician views the airway using a flexible fiberoptic or rigid bronchoscope that is introduced through the nasal or oral cavity. The airway is anesthetized. The bronchoscope is inserted and advanced through the nasal or oral cavity, past the larynx to inspect the bronchus, including fluoroscopic guidance, if used. After diagnostic visualization of the bronchus, a sample of bronchial or endobronchial tissue is removed for study. More than one site may be biopsied. It is important to note that code 31625 should be reported only once, even if performed at different anatomic sites. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with placement of fiducial markers, single or multiple. The bronchial biopsy is performed with biopsy forceps directed at visible bronchial tissue or a visible endobronchial lesion. After inspection of the upper airway and vocal cords, and usually after placement of an endotracheal tube, all of the airways are inspected and the site or sites for the bronchial biopsies are determined. The biopsy forceps is advanced through the suction channel of the bronchoscope into the airways. Bronchial biopsies are obtained from one or more sites and placed in formalin and sent to pathology. The bronchoscope is then withdrawn from the airways and removed from the patient. Bronchoscopy, rigid or flexible, including fluoroscopic guidance, when performed, with tracheal/bronchial dilation or closed reduction of fracture. The physician performs tracheal/bronchial dilation or closed fracture reduction using a flexible fiberoptic or rigid bronchoscope introduced through the nasal or oral cavity. The physician uses the views obtained through the bronchoscope to identify any narrowing or fracture of the trachea or bronchus. The physician introduces a wire through the narrowed or fractured part of the airway and removes the bronchoscope. A series of dilators or stents are passed over the wire to open the airway until sufficient dilation or closed reduction of the stricture or fracture is accomplished. This may be done with or without fluoroscopic guidance. A rigid or flexible bronchoscope is advanced to the stenotic area. A dilation catheter is placed through the bronchoscope into the opening of the focal stenosis and under fluoroscopy is threaded distally to just beyond the focal stenosis.